similar group of patients with metastatic BRAF mutant melanoma. I would like to introduce Dr. Axel Hauschild. He is the professor of dermatology at the University Hospital in Kiel, Germany.
Thank you very much, and good morning to everybody. It's my pleasure and an honor to present the BREAK-3 trial, which is a randomized phase 3 trial comparing a BRAF inhibitor, Dabrafenib. So we are walking upstream now from MEK to BRAF inhibition to the conventional chemotherapy with dacarbazine in stage 3 and stage 4 metastatic patients with melanoma. So this is a study design. The primary endpoint of this clinical trial is investigator-assessed progression-free survival. The trial was powered to detect a hazard ratio of 0.33. We screened 733 patients to enroll 250 patients for a 3-to-1 randomization to either Dabrafenib, an oral BRAF inhibitor, with a dose of 150 milligrams twice daily, or to conventional chemotherapy with DTIC with a dose of 1,000 milligrams per meter square every 3 weeks. So this was a 3-to-1 randomization since we had already phase 2 data in mind with a high response rate of 58% and a reasonable progression-free survival of more than 6 months. It was stratified for the stage of disease, so we were comparing unresectable stage 3, stage 4, the subcategories M1A and M1B compared to M1C of the stage 4 category. Of note, patients were allowed to cross over once they progressed on DTIC, and 68% of all patients who progressed on DTIC received subsequently Dabrafenib. Secondary objectives were overall survival and response rates in both groups and after crossover, but the data for overall survival are very immature. Only 12% of the patients died so far, and therefore the data are not presented here. Key eligibility criteria are the following. It's unresectable stage 3-4 disease. Patients were treatment naive for stage 4 disease except for interleukin-2, but only one patient received interleukin-2. Patients had a good performance status and they were allowed to enter the clinical trial even if they had CNS metastasis, but this need to be stable for at least 3 months. And the BRAF V600E mutations needs to be detected by an allele-specific PCR assay. So this is a primary endpoint PFS. According to the protocol by investigator assessment, the hazard ratio is 0.30, which translates to a 70% improvement of progression-free survival and death. And you see here the absolute numbers for Dabrafenib. It's 5.1 months in median. For DTIC, it's 2.7 months in median. And of note, on the bottom of the slide, you see that the median follow-up time is 4.9 months, equally distributed between the two arms. On the randomized study treatment, we're at the cutoff point, 57% of Dabrafenib and only 27% of DTIC patients. The best confirmed responses are shown here, and this highlights that Dabrafenib in investigator assessment showed a response rate of 53%, with 3% complete responders and 50% partial responders, and a very high number of patients with stable disease. So more than 90% of patients had disease control under this treatment. In contrast, DTIC in the investigator assessment showed 19% partial responses. If we go to independent review, you see virtually the same numbers of responses for Dabrafenib, but the number goes significantly down for DTIC to only 6% CRs and PRs. And you see the number of stabilized diseases is in a range of 37%. So this is the waterfall plot for Dabrafenib, which is very impressive. You see that almost all patients have a benefit on treatment with either stabilized disease or a partial or complete response. Very few patients showed a progressive disease under treatment. In contrast, the DTIC waterfall plot is shown here. There is some patients who have a benefit on the drug on the right-hand side, some patients with stabilized disease, but also very many patients with a progressive disease during conventional chemotherapy. This is the treatment-related adverse events in more than 5% of patients. And you see on the left-hand side that for Dabrafenib, hyperkeratosis was seen in half of the patients, and particularly hyperkeratosis of the skin and palmoplantar hyperkeratosis. But I like to focus your attention on the number of squamous cell carcinomas and keratocontomas If you sum them up, you come to 7%, 5%, which is translating to 9 patients showed in squamous cell carcinoma. There was some GI toxicity, but in very few cases it was grade 3, and in none of the cases grade 4. Arthralgia, fatigue, pyrexia were other common side effects with BRAF inhibitors also shown here. On the other hand, the most pronounced toxicity for DTIC, as expected, was hematologic toxicity. Here you see the number of patients who discontinued due to adverse events of the drug. It's very low for Dabrafenib with 3%, it's very low for DTIC with 3%, and the same numbers of dose reductions in the 2 groups of patients with Dabrafenib and DTIC, and the same numbers for dose interruptions and dose delays. So the treatment was well tolerated in the very most cases. So in conclusion, the BREAK-3 trial is showing a 70% decrease in the risk of progression or death compared to DTIC in BRAF mutated patients with a V600E mutation. Dabrafenib induced a significant anti-tumor response in 50% according to the independent review and in 53% investigator-based assessment. Very few adverse events and very few serious adverse events were observed when we were using Dabrafenib as well as DTIC, and the number of treatment discontinuations was only 3%. Of interest, squamous cell carcinomas and keratocontomas were not very often seen in only 7% of the patients, and phototoxicity was seen in 3% of the patients with Dabrafenib and in 5% of the patients with DTIC. So the next steps is a combination of Dabrafenib and the drug trametinib, which was introduced by Dr. Caroline Robert in the previous presentation, not only for stage 4, but also for the adjuvant setting, and an update on the combo is done by Dr. Weber on Monday in the afternoon session of the Clinical Science Symposium. Thank you very much for your attention.